There's our information, there's my information, and our objectives for those of you that are getting CEs. But let's jump right into vascular dementia. And what is vascular dementia? It was the second most common type of dementia, but as you're going to see as we go through this, it has actually been bumped to the third most common type of dementia because mixed dementia has become the second most common type of dementia. And mixed dementia is when somebody has at least two types of dementia. And it's almost always, but not always, Alzheimer's and vascular together. What we're finding, and there'll be a statistic in here later, I just updated all these statistics yesterday, is that a lot of people, when they pass at the end of the disease, at the end of dementia, they then find out they had vascular disease, especially if they have an autopsy. Some people, though, whenever you really start talking to families and digging into their history, the person has had vascular disease, and then they develop Lewy body or they develop frontotemporal. So they have frontotemporal and vascular at the same time. And we'll talk about what that looks like. It's very easy to think about what is vascular disease because when you think about vascular, you probably think of cardiovascular. So anything that's bad for the heart is bad for the brain. And what happens in vascular dementia is that there's a reduction in blood flow to the brain. Well, there's all kinds of things that can cause a reduction in blood flow to the brain, but the most common cause of vascular dementia or reason that we have vascular dementia is due to a stroke or a series of strokes called TIAs. And TIAs are little bitty strokes. We're actually going to look at an MRI of some. They can even look like pinpoints. They can be so small, but it can then cause issues with blood vessels. Other things that affect the cardiovascular system, like diabetes, smoking. Smokers are at a really high risk for vascular dementia. Hypertension that is not controlled, high cholesterol that is not controlled, depression that is not controlled. And we're going to tie those two together in just a little bit. There's now all kinds of research that shows that folks who have had untreated depression for many, many years later showing up with vascular dementia because of the changes that happen in the chemistry in the brain. Also, obesity is a cause of vascular dementia. And let's look at some of the reasons why. And again, it's because of the limited blood flow to the brain. So vascular dementia, again, many times coexist with other dementias. It also can coexist with depression, like we mentioned earlier. Vascular dementia is interesting because it is the one dementia that can come on suddenly. All of the other dementias that we see over and over and over again, Alzheimer's disease, frontotemporal, Lewy body, Parkinson's, each of those come on over a period of time. But with vascular dementia, a person can have a stroke and have dementia. So one day they didn't have it, and the next day they could have it. All the others come on over time. Now, vascular can also come on over time because, like that third bullet point talks about, it can develop gradually because think about what's going on in the blood vessels of somebody who is a smoker. That doesn't just happen overnight. That happens over time. Or with a diabetic or someone who has high blood pressure. That is something that is happening over time, that those blood vessels start to slowly narrow, and it is slowly depriving the brain tissue of oxygen. So we can see it either way, but this is the one that can come on suddenly. This is also the one that we have some control over because there are treatments for depression and obesity and high blood pressure and cholesterol and all of those things that we just mentioned. Where with the other dementias, we don't really know what makes that happen. Why do some people get Alzheimer's and some don't? Why do some people get frontotemporal and some don't? We don't know. So it can be subtle changes over time. Now, I want us to look at the prevalence. And again, this is some new statistics that those of you who follow or who work in healthcare, January and August is when new statistics do tend to come out. So we do have some brand new statistics that are just coming out. And so knowing that vascular has dropped to third behind Alzheimer's is the most common type or cause or form of dementia, mixed dementia is now number 2. Of vascular dementia, it's about 17 to 30% of all dementias. And it just depends on where the damage is in the brain as to what kind of, and again, those of you who are on our programs often know we're not using the word behaviors. We try to say expressions. Even though they may be challenging expressions, they are expressions. Now, this particular graphic of the brain also shows what's controlled in different areas. So if somebody has had TIAs or they have a stroke that it was in the temporal lobe, it gives you an idea of what the temporal lobe, what is in that temporal lobe or that frontal lobe. Some things that we can do to protect our brain, because like I said, this is the one that we do kind of have a little bit of control over. Maintaining a healthy lifestyle, having regular health checkups, doing those appropriate interventions. So that might be medications. It might be controlling underlying issues like heart disease or diabetes or other vascular problems. Being careful with our diet, our activity levels, stop smoking, using appropriate levels of alcohol consumption, being careful about alcohol consumption. And then you notice it says avoiding general anesthesia if possible. The number 1 accelerator of all of the dementias is general anesthesia. Now, general anesthesia is when someone is intubated. This is not twilight anesthesia. This is general anesthesia for a major surgery, a knee replacement, a hip replacement, a major surgery. If our loved one, or if we've got to protect our brains, have to have surgery, we want to talk to that anesthesiologist ahead of time. Let them know that we want the least amount for the shortest amount of time. They have all kinds of options now. I spoke with someone who works in this field very recently, and they said, absolutely, it's not like the old days where everybody got the same thing. They've got all kinds of options, so make sure that you do that. Symptoms of vascular dementia. Again, it varies widely because it depends on where the damage is in the brain. And some people early on, their memory loss isn't necessarily very significant. It may be other things like the third bullet point, impaired decision-making, impaired thinking, confusion, disorientation, trouble with the language, communication, not just speaking, but also understanding, and then those physical symptoms. So it may present in a little bit different way where we don't necessarily see memory loss right at the beginning or very much memory loss right at the beginning. And when we don't understand maybe aging, and we might think that somebody has had an age-related memory loss, and then we realize there's not age-related memory loss, there's age-related slowing down. We may think that this is just something that's part of getting older when actually they have had some TIAs, those small strokes, and we're not even aware of it yet. Some other things that we might see with vascular dementia is that not being able to do planning, so impaired planning, impaired judgment, even with things they've always been able to do. Or you may have seen this on commercials, uncontrolled laughing and crying. Some people call it emotional incontinence, where they may cry or laugh at inappropriate times, and it's because of the damage that's happened on the brain. We may see some pretty severe mood changes or mood swings, the inability to pay attention for very long, not functioning well in social situations, and then having a hard time finding words. Now, this is not where you or I are stuck on a word and saying, okay, just a minute, it's on the tip of my tongue. That's not what we're talking about. This is when they truly cannot find the word, and they end up using lots of thing and stuff. You know the thing, you know the thing or the stuff. You're supposed to figure out what they're talking about. Now, what will happen with vascular dementia is they'll ride those plateaus for a long time, and then there's a cardiovascular incident. And instead of it being a plateau and a slight progression, they will plateau and then stair step down. They'll have a big drop down because of the next cardiovascular incident. So how to get diagnosed with this? Neurocognitive testing is what measures brain function, and those results give a snapshot of what's happening right at that moment. Other things that they look at, of course, is memory loss, attention span, and how quickly a person can process information. So if they have an MRI, this can show evidence of strokes and other vascular changes. And let me show you what that looks like. There's arrows on these MRIs here. And where the arrow is pointing, you can see a lack of blood supply to the brain. So if you look at the one that is C, it's the lower left, and you see that arrow's pointing to, it almost looks exactly like a perfect black circle. And that's where somebody has vascular damage. Whatever is in that particular area of the brain, that's going to be the symptoms that we see, to where the rest of the brain isn't necessarily damaged. But I wanted you to see what it looks like, because if you've been on other programs where we've looked at pictures of Alzheimer's, Lewy body, frontotemporal, even Parkinson's, the brain looks a little bit different. But they can see this on an MRI. So what are the outcomes of somebody with vascular dementia? Their life expectancy is a little bit different. If they're diagnosed under the age of 65, the average life expectancy is about 3 years. And if they're diagnosed after the age of 65, their life expectancy is about 5. The reason that is because they typically have that underlying vascular issue, and that's what they end up passing away from, not from going to the end of dementia. They end up having vascular issues and they die from that. There are no drugs that are specific to vascular dementia, just like there's no drugs specific really to any of the dementias other than to treat symptoms. But there's not anything out there that is specific for vascular dementia treatment. But there are things where we can treat symptoms. This is where we continue to control the risk factors in somebody who has vascular dementia. And then if you notice that very last bullet point, and this is from the Alzheimer's Association, there's substantial evidence that treatment of risk factors may improve outcomes and help postpone or prevent further decline. So if somebody had uncontrolled high blood pressure, they have a stroke, and then we controlled their high blood pressure, they may sit on that plateau for a long time, very long time. I found a newer, updated video about vascular dementia. This is just a short overview of it, and I want us to watch this real quick. I think it's about 2.5 minutes.
Vascular cognitive impairment occurs when blood vessels in the brain are damaged or blocked, disrupting the supply of oxygen and nutrients to the brain cells. This can be found on scanning in people with no cognitive symptoms, but may lead to changes in function such as language, attention, reasoning, and memory. The most severe form of vascular cognitive impairment is known as vascular dementia. It can occur on its own, but it is more commonly found in a person who also has Alzheimer's disease or Lewy body disease, and this is known as mixed dementia. A major cause of vascular dementia is small vessel disease, where there is damage to the blood vessel walls within the brain. Vascular dementia can also develop after a stroke causes a blockage or rupture to an artery in the brain. It may also be a single stroke that causes these problems, or it might be a series of smaller ones. As a brain needs a healthy vascular system to function properly, a disrupted blood supply to the brain can cause symptoms of dementia.
The management of underlying health conditions such as high blood pressure, diabetes, and high cholesterol can reduce some of the risk factors for vascular dementia.
Vascular dementia is highly variable depending on the area of the brain that is damaged and other factors affecting the person's health. Symptoms may include a deterioration of planning, reasoning, and thinking skills, confusion, impaired attention, mild memory problems, difficulty finding the right words, slurred speech, changes in walking and movement, behavioral changes such as agitation, lack of bladder control, and depression.
Vascular dementia often occurs with another form of dementia. It occurs when blood vessels in the brain are damaged or blocked. Symptoms depend on the part of the brain damaged. Managing health conditions can reduce the risk.
All right, that's a really good overview. That was from Dementia Australia. They've got a great website. So let's look at some of the ways that we can treat and help vascular dementia. This actually is with all of the dementias that we're going to talk about these next 4 things. A person with dementia is going to go in and out of physical therapy, occupational therapy, and speech therapy throughout the course of the disease. I was actually speaking with some physical therapists yesterday in Arlington and telling them and reminding them that even though they are not curing the disease, this is not curative, what a difference they make as far as comfort measures and quality of life goes. So again, they're going to go in and out of therapies, but you've got to make sure you have a therapist who knows how to work with somebody with dementia. Otherwise, they're going to mark them as non-compliant, saying that they're not following directions, and they're going to go on to their next client. So we want to make sure and ask if our loved one is going into therapy, that they have people who are trained in dementia. But think about why physical therapy and occupational therapy is going to make such a difference in somebody with dementia. And on this one, we're talking specifically about vascular dementia. They know how to tap into things like procedural memory, and they know how to tap into muscle memory. And muscle memory is still there in a person with dementia well into the disease. So some of the reasons that we might do physical therapy is to help in the reduction of fall risk. We know that eventually they're going to start to have a lot of falls because when we learned to walk, we had a lot of falls. So when they're to the point in the disease that they're about to stop walking, they're going to have an awful lot of falls. It also helps increase their circulation because so many times when someone's at home, they're doing a whole lot of sitting in the chair and looking at the TV. So having that physical therapy gets them moving and helping with muscle tone, flexibility, their balance, and their mobility. Occupational therapy, oh my goodness, occupational therapy I've seen make such a difference in family lives because they really work on those activities of daily living. And so activities of daily living is where they still can do things like feed themselves, dress themselves, toilet themselves. And that occupational therapist can even come in and show you ways to adapt your own home to make it a safe place for somebody with dementia. A physical therapist can show you how to safely lift, move, and transfer your loved one. You just have to ask them to do that. Also, occupational therapy can show you how to use and where to get things like adaptive eating utensils and other adaptive type things. You can go on places like Amazon. There's something called ALZ store, ALZ store, and they have all kinds of adaptive utensils for people with dementia. Speech therapy and music therapy are the other 2. Now, so many times when we hear the word speech therapy, we think that this is specific to speech, but especially with somebody with dementia, this is going to be a lot about swallowing, because think about what controls how we swallow. That's our brain. And so eating, drinking, and swallowing. The speech therapists are the ones who do the swallow test, and they are the ones who can tell us when it's time to change the diet of our loved one, when they go from a regular diet to a soft, maybe to a finger foods, to a pureed diet, or when it's time to thicken liquids, because there does come a time that they're going to do better whenever they have thickened liquids. And music therapy we know is great throughout the course of all of the dementias, simply because we know that that amygdala stays intact in the brain, and the amygdala controls those feelings and those emotions. We know the right side of the brain deteriorates slower than the left, and the right side is where rhythm is. Right rhythm remains. And so it is a great mood stabilizer. It helps us connect with our loved one if we do something with music together, whether it's dancing or whether it is beating on a drum together, or whether it is just sitting, listening to something and tapping our hands together. It really makes us be social. Other interventions that we can do for vascular dementia, you're doing part of it right now, is education to understand the disease process better, making good choices as far as, again, anything that's good for the heart, good for the brain, anything that's bad for the heart, bad for the brain. Making sure the person is getting adequate rest, looking for any reasons behind a behavior. If you do have a challenging behavior or a challenging expression, about 80% of the time when we see that, it was either our approach, our tone, the gestures we were using, or our body language, or the environment that caused it. We didn't do it on purpose. They're trying to get a need met, and we have to figure out what's the reason behind the behavior. And then the 4 things that we use to redirect: food, music, animals, and children. Food, the sweeter the better. Music, their music, especially their music from the time they were 10 to 25. That's called our music set. And when you study music therapy, that for all of us, that is our music set, from the music between the ages of 10 and 25. And then animals and children. YouTube is wonderful. Type in funny baby animals falling down. That's one of the best. Or children laughing. That's another really good one. And use something a little bit bigger like an iPad to show them videos. Things that we can do to help somebody with dementia. Educating yourself is a big part of it, and switching to focus on quality of life. Not necessarily how long are they going to live, but how well are we going to live, because there's quality of life to be had with dementia. Practicing that self-care and compassion is huge when we're a caregiver of somebody with dementia. And then keep in mind that last bullet point: the person with dementia is not giving you a hard time. The person with dementia is having a hard time. Now I've got resources for each of the sections. And so this section is on vascular dementia. So here's some local information here in Fort Worth. Also, there's TIPA Snow is on there. The Alzheimer's Association is on there. And then the others are local. And then here's resources for all of the statistics that we did today. And again, you're going to get copies of all of this. And let's start talking about stroke. Because we said the most common cause for vascular dementia is a stroke, and there are 2 different types of stroke. So we need to understand that there are 2 different kinds. There's the ischemic stroke and there's the hemorrhagic stroke. So if you'll, I found this graphic that I thought, wow, that really explains it in a way that we can understand it. In the ischemic stroke, it's an obstruction that's blocking the blood flow to the brain. In the hemorrhagic stroke, look what happens there. That's when the wall ruptures and there's bleeding in the brain. But what it comes down to with a stroke, there's a supply of blood carrying oxygen to the brain, and it is suddenly cut off for one reason or the other. And vascular dementia, again, most commonly caused by strokes, whether it's a big stroke or a number of small strokes. But hear this also, not everyone who has a stroke is going to develop dementia. Not everyone who has a stroke is going to develop dementia. Stroke symptoms, and you may have seen this, they came out with this fast, this graphic is really good. Looking at a person's face, does it look uneven? Is one arm hanging down? Is the speech slurred? And then making sure that we call 911 immediately, because time is so important. We've got some other symptoms that are listed there: trouble seeing, a metallic taste in the mouth, trouble swallowing, difficulty walking. All of those also can be a sign of a stroke. Diagnosis and prevention of a stroke. So again, they're going to do a physical exam first. They're going to do a blood test. They likely are going to do a CAT scan and an MRI, because you can see a stroke like we saw earlier. They may do an ultrasound also to check for the blood flow in the carotid artery. Some of the things that we can do to prevent stroke, and the first one that's listed is a diet. And this is a diet that is rich in fruits and vegetables, maintaining a healthy weight. One of the best diets that we know that we can follow. And some of you, we've talked about this before on support groups and different programs. There is a diet now that is called the MIND, M-I-N-D, MIND diet. And it is a combination of the Mediterranean diet and the DASH diet. The DASH diet is the diet that came out that is specific for people with high blood pressure. Well, some neurologists got together and they combined that DASH diet with the Mediterranean diet, and they came out with the MIND diet. Supposed to be the best diet for our brains. That's good for all of us. Again, other things is controlling diabetes, cholesterol, blood pressure, depression, avoiding illicit drugs, controlling alcohol consumption, stop smoking, and then treating sleep apnea. We know that there is a link between untreated sleep apnea and vascular dementia or stroke, because think about what's happening with sleep apnea. We stop breathing. We're not breathing. And those of you who have it, or you know people who have it, I have it and use a CPAP. When you have that initial sleep study, they tell you how many times you stop breathing during an hour. And sometimes it can be really scary. And then again, think about what's happening when we stop breathing. So we now know that there is a correlation between untreated sleep apnea and vascular dementia. Treatment for stroke. This is why time is so important, because we now have clot dissolvers that they can give us, and it will dissolve the clot, open the arteries, anticoagulants. So we want to make sure and call 911, get them to the hospital as soon as possible. And if they even think that it is a stroke, they have got medications that they can use. There's procedures that they can use for a stroke. They can use catheters, they can use angioplasty and stents. They can even clip aneurysms at this point. So there are things that can be done. There are therapy that's specific to somebody who's had a stroke in rehabilitation, and we want to get them into that therapy as soon as possible. They typically are going to start with speech therapy, because it's very common in someone who's had a stroke that they will lose part or all of their speech. They can even do some cognitive therapy that again is specific to people who've had strokes. They'll work on sensory and motor skills, and of course, physical therapy. Now, some of the things also after a stroke is usually that person is going to be on a very strict diet. They'll probably send us to a dietitian, and then they're going to recommend things like fruits, vegetables, whole grains, lean meats, low fat, and limited salt intake. Also avoiding anything that has heavy cholesterol, alcohol, and foods that are high in salt and sugar. And then I wanted you to see, here are some more images, and these are specific to stroke. And these, if you notice, especially like that top left corner, you can really see where that stroke is. All of them, I mean, it stands out. You can see, thank goodness, we now have the ability to see the stroke and see where the stroke is. And then the neurologist can talk us through, okay, that particular area of the brain controls this. So you're probably going to be seeing, it gives us an idea of stroke related behaviors that we might see. And I want us again to watch a very short video that is specific to things that might happen when someone has had a stroke.
A stroke is when the blood supply to part of your brain is cut off. This can cause your brain cells to become damaged or die. A stroke can happen to anyone, and there are two main types. The most common is an ischemic stroke, which happens when a blood vessel in the brain becomes narrowed and a blood clot forms, causing a blockage. Sometimes this blockage is only temporary. This is a transient ischemic attack, or TIA, and is often called a mini-stroke. A TIA may feel like a funny turn, as you may experience slurred speech or confusion for a short time, and then go back to feeling well again. The other main type of stroke is a hemorrhagic stroke. This happens when a blood vessel ruptures, causing a bleed in the brain, permanently damaging the surrounding brain cells. Risk of stroke is increased by an irregular heart rhythm called atrial fibrillation, or having risk factors such as being older, having high cholesterol, high blood pressure, diabetes, smoking, or being overweight. Penny was at home when suddenly her face dropped on one side. She was unable to raise both of her arms, and her speech became slurred. Her husband immediately called 999. At the hospital, doctors gave Penny a clot-busting drug to break down the clot in her brain. Some people may have an emergency thrombectomy, a procedure to remove the clot completely, or another treatment to try and restore blood flow to the brain. The treatment given will depend on the type of stroke you've had. After her stroke, Penny's family noticed mood and personality changes, and she wasn't able to do as much as before. Depending on the area of the brain that is damaged and how quickly they receive treatment, people may also experience memory loss, tiredness, difficulty swallowing, muscle weakness on one side, or problems communicating. These can be permanent, but many improve over time. Following a period of rehabilitation in hospital, Penny made some lifestyle changes to continue her recovery and reduce her risk of suffering another stroke in the future. Whilst the effects of a stroke can be devastating, if you act fast and get the treatment you need immediately, this gives you the best chance of making a recovery and getting back to a normal life. More information on strokes can be found at bhf.org.uk/stroke. BHF, beat heartbreak from stroke. Beat.
And of course, they said 999 to where ours is 911 because that's from the UK. But I thought the graphics in that were easy to understand. And there's so many different things that they can do now for stroke. We're going to move into depression and dementia. Now, we know that early in the disease, that a person who is in the early stages of all dementias many times has depression because of the diagnosis that they've been given. It also can be because of the changes that they know are happening in their own body, whether they're admitting it to us or not. We all know when something is going on with our body and something's wrong. So we will see people have depression in the early stages. We then see it again in the later stages of the disease, but it's because of the chemical changes that are taking place in the brain. So what we're going to talk about right now, though, is depression throughout a person's life, that if it goes untreated, there is now a direct link between untreated depression and later developing dementia. I've got a graphic I'm going to show you next that really links the two together. There's more and more studies being done on this. And I think it's really interesting for us to look at because I talk to so many families who say things like, oh, my mom has struggled with depression her entire life. She wouldn't take antidepressants because she thought she's going to get hooked on them. And then they end up with vascular dementia. We're going to talk about each of those things. There's overlapping symptoms between some of the earlier stages of dementia and depression. But depression and anxiety are the most common mood disorders in the United States. And as a licensed therapist myself, I hate that we use the word mental illness and that depression and anxiety fall under what technically is called a mental illness. It's brain health is what it is. And I think if it did not have the stigma of being a mental illness, maybe we'd talk about it a little bit more, and maybe we wouldn't be ashamed to talk about our brain health, because there's not anything to be ashamed of. We talk about our heart health with no problems. People will share, I'm on blood pressure medication, I'm on cholesterol medicine. Nobody wants to talk about an antidepressant. Only a third of people who have depression are actually receiving any type of treatment. So let's look at what is actually happening to the brain whenever a person has depression and how it can end up leading to dementia later on. Depression is changing the brain. It changes the chemicals in the brain. And look that now we know it actually can increase those amyloid plaques. And many of you know enough about dementia to have just heard the word plaque and go, uh-oh, that's Alzheimer's disease. Those other types of dementias where we've got plaque. Inflammation also, and then it leading to dementia. Here's another scan. The healthy brain is on the left. Look at, especially in this frontal cortex. Depression actually changes the metabolism and blood flow, and it pulls it away from the frontal cortex, because look at the brain that has chronic depression. It doesn't have the same blood flow in it. It damages the brain due to the chemical changes. And that's what antidepressants do, is they help stabilize those chemical changes in the brain. One of the areas that can be damaged from depression is conflict resolution. We can see there from the scan, the prefrontal cortex. Part of what's in the prefrontal cortex is planning and executive function, being able to be reasonable and rational. So a hypothesis is that vascular depression is caused from these vascular lesions that are on the brain because of untreated depression. This has really been coming out in the last 2, maybe going on 3 years that they're studying this. So let's look at what is depression. And again, we're going to look at some brand new statistics that just came out on the next slide. A person can be depressed and not be sad. Although typically when we think of depression, the first thing is we think of is sadness, loss of interest in activities, because those are the most common things. Just like when we think of dementia, we think of memory loss. But then there's a couple of different types of dementia that present with no memory loss. So a person can be depressed and not necessarily be sad. But what happens with depression is that it can lead to other emotional and physical problems. So here's these latest statistics. These are 2022 statistics from the CDC. And it was interesting how some of these had changed over the last year. One in particular, number of physician office visits with depressive disorders as the primary diagnosis, were about 15 million in the United States last year. Number of suicides in the United States last year, over 48,000. This is a typical patient health questionnaire. And the way that we answer this, it's one of those, I'm not crazy about these answers, but it's now what they have you do is they think over the last 2 weeks, And again, you're going to get a copy of this. And I want you to really look at this slide 32 and think about it for yourself. Think about it with others around you. Again, you think of the last 2 weeks, would your answer be not at all, several days, more than half the days, or nearly every day? And be honest about it. And be honest about it without saying something like, but I, Well, yeah, I've got that going on, but that's making an excuse. We got to admit there's something going on before we can seek treatment. Now let's look at these signs and symptoms of depression, because just like with dementia that has over 35 common symptoms, and most people can only name 2 or 3, depression also has a lot of symptoms. And what yours looks like and what mine looks like may be completely different, because it affects different people in different ways. So take a look at that. I encourage people to get a highlighter, run this off, and highlight any of the ones that you've had in the last month. And especially if you are a caregiver of somebody with dementia, being able to, because what I have found is people will go, well, yes, I'm having feelings of guilt or feelings of worthlessness or loss of interest in my hobbies or aches and pains in my back, but I'm a caregiver. Exactly. You're a caregiver. You're having what's called, and we're going to talk about, situational depression. This is depression caused by the situation that you're in right now. It's not because of something you did, it's because of the situation that you're in right now. So these are common signs and symptoms of depression. Now, I want us to also look at what depression might look like in an older adult. And by older adult, the Mayo Clinic is using 65 and older. It can look a little bit different. Now, keep in mind that just like dementia, depression is not a normal part of growing older, and it should never, ever be taken lightly. Because white men over the age of 75 have one of the highest risk of suicides of anybody. Depression will go undiagnosed and untreated in older adults many times because they're reluctant to seek help or to talk about it, or they think it's just part of getting older. It can show up as memory issues, personality changes, physical aches and pains, kind of becoming antisocial, that feeling of hopelessness, fatigue, even starting to have some difficulty performing tasks. And I want us to look at, there's many different types of depression. We do not have time to go over all of those, but I just have 5 pretty common ones here. And I want us to look at this first one, which is kind of a chronic depressive disorder. This is a depression that lasts for a minimum of 2 years, and it's almost like the major depression comes and goes. And in the periods where it kind of wanes, the symptoms aren't as severe, but they're still there. Those symptoms that we looked at earlier. But to get a diagnosis, these need to have been present for 2 years. Postpartum depression, you've probably heard of, a major depression during, after delivery. This is not normal baby blues. This is something much more intense than that. It makes it difficult to even care for the baby or care for ourselves. Seasonal affective disorder is usually seen in the fall or winter, but some people have it in the spring or summer. But for the most part, we see it in the fall or winter when the days are shorter, there's not as much sunlight. People will start to withdraw socially. They may sleep more, they may gain weight. Sometimes we'll use something like a light therapy to help with that. And then there's major depressive disorder, and this is also called clinical depression. We saw a real rise in this during the pandemic. I think a lot of us probably, there was post-COVID depression. That was a very real thing, still is. And then a lot of us went through a major depressive episode because of the pandemic. This is where we were having those symptoms that we saw earlier that were starting to affect our daily life. They were affecting our work, our sleep, our study habits, the way we were eating. And we might have one episode during a lifetime, or we may have multiple episodes. And then this is what I mentioned earlier, situational depression. And this is where we have depression because of the situation that we're in. We're going through a divorce. We've lost a job. We have a loved one with dementia. Grief comes in waves where it feels like it can just knock us down. In my grief support group, we use the term grief burst, where it is like this burst of grief that comes out of, where did that come from? I'm standing in the middle of a grocery store. But then there's other times that I'm okay. I'm still standing in the middle of this water, but the waves aren't knocking me over. During situational depression, self-esteem is usually maintained, keeping in mind that grief and depression can coexist and often do. Let's look at the risk factors for depression. Again, it's big to see that only 1/3 of people actually receive treatment. We see a lot of depression in families. About 40% of the time, there's a family history. And what's interesting with identical twins, that if one twin has depression, about 70% of the time in identical twins, they'll both have depression. We do see more depression in women than in men, and part of that is due to hormonal factors. In fact, about 1/3 of women will have at least one major depressive episode during their lifetime. It can be environmental. It can be due to violence or neglect or abuse or a pandemic, stress and trauma, a person's personality, a diagnosis of a physical illness. Depression and surgery go together, especially situational depression, where maybe we have a surgery, we're having to depend on other people. I don't know how I'm going to do. I'm going through therapy. Physical illness and depression go hand in hand. And then sometimes it's a side effect of a medication. Now, I think it's interesting to note here a couple of ways where men and women differ in depression. For women, the 3 most common things that we see are sadness, a feeling of worthlessness, and guilt. I bet some of you are shaking your heads. And in men, the 3 things we tend to see are fatigue, being tired, irritability, and being angry. Makes sense when we think about it. How we get diagnosed for depression or with depression. To get a diagnosis, the symptoms need to be present for at least 2 weeks. And typically by the time we talk to anybody about it, what I've found, being a licensed therapist myself, is people are long past 2 weeks before they start to talk about it. But we can go to our primary care physician and have a diagnostic exam, an interview, a physical exam, lab tests to rule out other conditions, because things like vitamin deficiencies and thyroid problems can mimic depression. So we're going to want to have a complete blood workup. And then we want to look into a medical and family history as well as things like cultural and environmental factors. A person can also go see a psychiatrist, which can do the very same things as that primary care physician, but this is someone who specializes in mental health. They can perform therapy themselves. More often than not, they're going to send you to a counselor, but they also can prescribe medications and recommend a therapist. There are people like me, a licensed professional counselor. There are licensed clinical social workers, licensed master social workers who can do assessments and then do therapy. We're going to talk about some different types of therapy. And then there's psychologists that can also do in-depth psychological testing if it's needed. Now, I think this is important to see, because most people don't realize this, that 80 to 90% of the time, treated depression can be cured. That doesn't mean that it's never going to come back, especially situational depression. And then another 20% of the time, even in treatment-resistant depression, we can reduce some symptoms. I've just read Naomi Judd's book that she wrote about her treatment-resistant depression. It's hard to read. It's a hard read. But when she was treating her depression, and she tried all different types of things, she would at least see some reduction in symptoms, but she could never get to that point where it completely went away. But 80 to 90% of the time, it can be cured. But only a third of people seek treatment. And the earlier we get that treatment, the more effective it is. There is not a one size fits all treatment for depression, because it's different in everybody. So let's look at medication. It's so important to understand that antidepressants are not habit forming, and antidepressants are not uppers. Some of you may remember back in the 90s when Prozac first came out, there were rumors and people were saying that you could get high using Prozac, and that isn't how it works. That's not how it affects the brain. It takes a while, and what happens is lots of times by the time we talk to a doctor or a therapist about depression is we're to the point that we want to take a pill right now and have it fix it today. And that isn't how it works. It can take 2 to 4 weeks and sometimes 2 to 3 months for it to completely go into effect. That's why the earlier we go talk to somebody, the quicker it can help. And for many people, this is short term. It can be 6 months. While we're also doing some type of psychotherapy, we're doing some talk therapy, or some other things that we're going to look at. But one of the things that we tend to see is that once somebody starts to take an antidepressant, within a couple of weeks, sleep improves, and that's huge. We know that. Appetites change, and concentration improves. Now, there's different types of therapy as well that I want us to talk about. Cognitive behavior therapy is probably the one you've heard of the most, and it's used the most often. I use cognitive behavior therapy in my support groups all the time, where we focus on problem solving and reframing the situation. It helps us recognize distorted thinking that we're having, or sometimes we call that twisted thinking that we're having, or even just negative thinking. And the goal of cognitive behavior therapy are to change those thoughts and respond to challenges in a more positive way. There's other types of therapy, interpersonal therapy, problem-solving therapy. And for those that need to really do some deep therapy about trauma that may have happened to them, you may have really been hearing a lot about EMDR, the eye movement desensitization therapy. It allows people to heal from emotional distress of trauma from their past. I specialized in something called narrative therapy, where I use a person's story to build their therapy around their story. There's other things that we can do for depression. And usually when we're depressed, the last thing we want to do is exercise, but it's actually one of the best things that we can do. So I encourage people to commit to 15 minutes. Could you do 15 minutes 3 times a week? Because most all of us can say, I can do that for 30 days. I'll commit to doing that for 30 days. And then we start to feel a little bit better. That's part of the setting realistic goals. We've got to set something that we know we'll do. Because if we say, I'm going to exercise an hour every day, well, we know we're not going to do that. Educating ourselves about depression. Setting some priorities, breaking tasks into smaller ones. Sleep and diet are huge. And then, last bullet point, to avoid self-medicating. And we can self-medicate with all kinds of things. Alcohol, drugs, food, shopping, pornography. There's all types of things that we could, Netflix. There's all kinds of things that we can self-medicate. Let me just leave this reality for a little while and enter into. And there's a time and place for sometimes. I am a big person on saying, let's go watch some Carol Burnett for a little while, but I'm not going to sit there and watch it for 8 hours. How do we help people that are depressed? Offering their support. And what I tell people, what I tell folks is you don't necessarily have to try to fix it. Just be an ear. Because sometimes we just need somebody to hear us without trying to fix it. Don't ever ignore somebody's comments about suicide. Invite them to get out of the house. Let's go on a walk. Let's go on an outing. Let's go to a movie. Let's go to a restaurant. Just us. Making sure they have transportation to their appointments and that they're keeping up with their treatment plan. Here's some information about where you can get help and some resources. And then I hope that everybody is aware of this, but this went into effect last July. So we've had it now for a year. There is now a number that's 988. And when you call 988, you're going to get somebody who is trained. It's a crisis hotline is what it is. So you can call it if you feel like you're in trouble yourself. You're going to get somebody who's trained. You can call it if you're having a problem with your loved one. You're going to get somebody who's trained. If you ever have to call 911 because of your loved one with dementia and you are needing help from the police, please make sure that you ask for the mental health officer, because most big cities now do have mental health officers that are trained. But notice there on that 988 lifeline, it's a local crisis center that provides free and confidential emotional support to people in distress. You don't have to be suicidal. You can just be in distress, and you call 988 and you're going to get somebody who's trained to help. There's our information. I know we're right at time. Let me stop and let me just add, for those of you who may have joined late, that we do have a free CE with this. Jamie Cobb Tinsley will send out an email in just a little bit with the recording of this and with the slides. Let's see. Being contagious, we're often talking about symptoms of depression from the hardships we face. That's right. We do sometimes joke about dementia being contagious, but you're exactly right. It's not contagious, but those symptoms. Yes, men can also show depression differently. Yes, anger and frustration. You're right. And it's appear from people's individual. That's right. That's right. From staying indoors too much. Thank you so much for adding all of that. I appreciate all of you being on here today and taking your time to be with us. Be looking for an email from Jamie, and she'll send you the slides, the copy of the recording, and information on how to get your CE. Thanks, everybody. We'll see you next time.